So we're going to talk about LVO and thrombectomy kind of workflow and management of these cases here at Elmhurst in particular. This is our slides and a talk that Dr. Shora put together with Magda, but Dr. Shora can't be here this morning. So I will be going through this. Again, we will be putting this up on our Elmhurst Neurosurgery YouTube channel so that people can view it later as well. So some of the objectives for this is want to just give a little bit of an overview of large vessel occlusion. So that's what LVO stands for, large vessel occlusions, which are a subset of strokes caused by occlusion, obviously, of a large vessel, and we'll kind of define what that means. What are the advances in LVO treatments, including thrombectomy, care of the thrombectomy patient in the emergency department, care of the thrombectomy patient in the angio suite, and postoperative care of the thrombectomy patient. As we all know, stroke is a major neurological disease and a very significant cause of mortality and disability in high-income countries and in the United States. It's the fifth leading cause of mortality and the first cause of disability. And in New York City in 2011, a little bit outdated numbers, but there was over 1,700 patients that died from a stroke in New York City. So when we talk about large vessel occlusions, we're really talking about a very particular type of stroke that is one of the more devastating forms of ischemic stroke, where you have occlusion of one of the large vessels, really either one of the intracranial ICAs. So if you see this picture over here, you have the vertebral arteries here, kind of going up to the basal artery, which is considered the posterior circulation. Then you have the ICAs coming here extracranially, and then somewhere in this area here, it's going to go through the base of the skull and intradural, and then split. And so this is the other side on this ICA. And then you're going to, so your intracranial ICA is basically this part here. And then it's going to split into the anterior cerebral artery going medially and middle cerebral artery going laterally. And so the portion right after it bifurcates before another vessel comes off is going to be the A1 here. And then there's an anterior communicating artery, which joins the two ACAs, and then past that is A2. The M1 is this first part, and then off of the M1 are actually all of these lenticular striate arteries, and so these are, you can also have a stroke from thrombosis of those, but those are not large vessel occlusions. Those are smaller strokes. Those are the ones that typically give you like lacunar strokes, things like that in the basal ganglia, and those can be obviously very symptomatic and significant, but you're not going to get like a massive stroke that affects multiple areas of the brain that causes potentially a ton of swelling and that is likely to, potentially kill you from the stroke. I mean, you might have a significant neurological deficit, but a lot of those patients do get better pretty significantly. And also, to remove a clot from these little tiny arteries is extremely difficult, if not impossible. Some of these arteries are, a millimeter or two wide, basically. So you have the M2 that comes out here, and then when the MCA bifurcates, M1 as it come out, and then the MCA bifurcates, and then you have the M2, and then the M3 and 4s are basically on the surface of the cortex. So when we talk about a large vessel occlusion, we're really talking about a clot, a thrombus, either that forms in that area from plaque or an embolic stroke that goes up and then the clot gets lodged in one of those large vessels. So the intracranial ICA, middle cerebral artery, M1 or M2, anterior cerebral artery, A1 or A2, and the basal artery. Because basically, if you occlude these ones, you're going to have a significant territory of the brain that is going to have decreased perfusion. You're going to have quite a large stroke that's going to affect multiple areas. Obviously, the basal artery could, you will end up potentially infarcting the brainstem, and so that one you could get like locked in or die from that relatively quickly. M1 or an ICA can give you a very large stroke in the hemisphere that could cause significant swelling that you might cause you to die from that as well. And even if you do survive, you might have pretty significant deficits from the size of the stroke that has occurred. And this is just an angiogram showing you what it looks like. So this is kind of an AP angiogram with the right ICA here. This is A1 here. These are the two ACAs coming off here, and you can see here where M1 should be going out. You should see a bunch of vessels out here. This is extracranial vessels here. But you should see the MCA and all its branches coming out here, and you don't. It just kind of stops and truncates off. So that's an M1 occlusion here. And on a CT scan, what we'll often see is like a hyperdense MCA. So here on the left side, this is the abnormal NCA. You shouldn't really see the MCA on a non-contrast CT scan, but if you have a thrombus in it, it can look hyperdense because basically you're seeing the thrombus within the middle cerebral artery, essentially. So dense MCA sign is what that's called. So large vessel occlusion. So not only do they cause a, because they're affecting a larger vessel that is perfusing a much larger area of the brain. Not only does it affect a larger area of the brain, but these clots are much bigger than the clots that are in like a little tiny lenticular striate vessel, like lenticular striate vessel. So most of these large vessel occlusions, most of the thrombuses that are in thrombi that are in those large vessel occlusions, they don't improve with just thrombolytics, unlike the lacunar strokes and the smaller lenticular striate strokes. So 2 out of 3 will not improve with either TPA or tenecteplase. 3/4 will be dependent still at 90 days, and there will be a mortality of about 20% at 90 days. And there's about 24 LVOs per 100,000 population in the United States. So Western Queens has a population of about 1 million people. So in the catchment area of Elmhurst, there is theoretically around 240 LVOs per year. So that's, not quite one a day, but pretty close. So that's quite a significant number. And then and in New York City proper's got about 8 million people. So in about New York City, right, that would be about 1,600 LVOs per day. I mean, per year. So 1,600 would be about, 8 or roughly or so per day. Not quite 7 per day. So for a long time, there wasn't really any good treatment other than TPA until people started looking to see if there was a way they could use neuroendovascular treatments to basically open up the blood vessel and reperfuse the area of the brain that is related to that blood vessel. So there have been multiple different trials looking at this, and for a while the data was not great, but then recently, as the technology has become more sophisticated, and as the workflows have developed to allow people to do the thrombectomies earlier and to get to these patients sooner so that they can recanalize and reperfuse the brain earlier on. It's been very clear that neuroendovascular treatment is significantly favorable in the vast majority of these patients. And so the odds ratio are really 2.5. So you're 2.5 times more likely to have a favorable outcome if you get endovascular treatment if you have an LVO than if you don't. And if you look here, just on kind of like overall control population is patients that did not get thrombectomy. You can see, so these are Rankin scales. So Rankin scale of 0, 1, and 2 is good. 0 is like no disability. 2 is kind of like not quite, like 3 is like moderate, so it's kind of still minor. But basically independent. 0, 1, and 2 are all independent. 3, 4, 5, 6 is dead. So you can see that, without treatment, like almost 20% were dying, and then, there was only really 25% that were doing well. But in those that got thrombectomy, that's increased up to almost 50% that are doing well. That's like 26 and 20, so like 45%. So significant improvement in the number of patients that are doing well after endovascular treatment. And the number needed to treat is 2.6, and this is extremely low. This means that, you only need to treat 2.6 patients for one patient to go from having done badly to doing well. And this is actually significantly low. Most very few surgeries or interventions have this low of a number where you only need to treat like basically every other patient that you're treating is somebody that would have, done very poorly and now is going to do much better and go back to a functional outcome. So why kind of did the data and the newer trials for endovascular therapy improve when, endovascular therapy, or endovascular techniques have been around for a long period of time. Angiograms, things like that started out in the 1950s. And even, by the 1990s, people were doing neuroendovascular procedures and people were taking out clots here and there, but it didn't really become standard of care until, 15 years ago or so, I would say. And really, in the last 15, 10, 15 years is really when neuroendovascular therapy for strokes has become mainstream and standard of care. And so again, as I mentioned, three of the reasons why these trials have become why these trials have succeeded and is that the technology's gotten better. Workflows have kind of surrounding these have allowed us to get to these patients earlier. So basically, stroke systems have developed similar to how trauma systems have developed. So, as you all know, trauma systems have been around for a fair amount of time, and those are quite organized with EMS taking people to different levels of trauma center and trauma centers being devised to get patients into the OR rapidly and things like that. And basically, the same thing had to happen with stroke, and now stroke is just as sophisticated, if not more sophisticated than trauma in terms of getting patients to thrombectomy centers and to stroke centers and getting them into the thrombectomy suite so they can get their thrombectomy in as short as time as possible. And then T is target, in other words, like refining kind of like the patients that are likely to do well with this therapy and really targeting those patients as opposed to, ones that may not be the best ones to intervene upon, either because they don't have a severe enough stroke and severe enough symptoms, or because they already have too much injured brain and are likely then to have, hemorrhagic complications. So technology. I won't be able to get into this as much as Dr. Shora has, but there has been significant advances. Every year it seemed like for a long time that there was a different new type of device that was being used in thrombectomy. They have like the penumbra device and suction devices that allowed you to suck out the clot. They have like coils or that basically can you basically pull the clot out with these kind of mechanical retriever type designs, and then they also have ones that are kind of more like stents that can be used. And at first they were just using kind of regular stents to do it, but then they started developing stents specifically to help grab the clot and these longer clots where then it can pull out the entire clot with the stent essentially. And basically as the technology has advanced, it made it easier and more facile for them to remove these clots without injuring the underlying blood vessel, which is obviously very important, because you don't want to injure the blood vessel and then have the blood vessel clot off again because it's been injured, or the blood vessel rupture or hemorrhage, obviously. So one of the ways they score how well you've reperfused the area distal to where the clot is called the Tiki score. So it goes from grade 0 to grade 3. There's 5 different grades. A grade 0 would mean that you don't get any increased perfusion, or you have no perfusion past where the clot was after you've tried your thrombectomy. So that's obviously a thrombectomy that's failed. So that's not ideal. The exact opposite is a grade 3, which is where you have full perfusion with filling of all the distal branches. So that's always the goal, is that we'd like to see a Tiki 3 result where after the clot has been removed that you have full perfusion. One of the next best one is a grade 2B, which is where it's not full perfusion, but it's perfusion of at least half or more of the vascular distribution of the occluded artery. So usually, we consider it's considered a successful thrombectomy, really, if it's a grade like 2B or a grade 3. These are, it's not uncommon that a grade 2 will improve to a 3 after kind of like, some of the vasospasm may have resolved and, just give it a little bit of time. And usually the grade 2B will end up becoming a grade 3. Grade 1 is obviously better than no perfusion, but so there is some perfusion getting past the initial obstruction, but it's limited and there's little or slow distal perfusion. And then a grade 2 is perfusion of less than 1/2 of the vascular distribution of the occluded artery. So in general, you're trying to get it to a 2B or a 3 if you can. So time, multiple studies, have been done, as I mentioned, in the last 20 years or so. And basically what's been shown is if you looked at, and they all had different kind of like times that they had to get patients into a thrombectomy suite and get reperfused. And, as we've gotten, as we've done more and more of these trials, kind of the time has steadily marched downwards in terms of what is acceptable in the trial, as technology's gotten better and workflows have gotten better. And so kind of the older trials where, you had a little bit longer symptom onset to reperfusion time that was allowed. And, nowadays you're really trying to get that in under, 3 or 4 hours basically. And what's been shown is that if you then plot out how patients did, the percentage of patients with a good clinical outcome of 90 days significantly increased the faster you were able to reperfuse them, which makes sense, right? The longer it takes for you to open up the blood vessel and reperfuse the brain, the more brain cells that are going to have died during that period, and more likely than the worse the patient is going to do. And if you look at this, it's every 30 minutes, there's every 30-minute delay to reperfusion is a 10% reduction in the odds of a good outcome. So if it takes 30 extra minutes to get the patient because of like CT issues or consent issues or whatever into the angio suite and get them reperfused, that's actually reduces the chance of them having a good outcome by about 10%. So time is brain, and we want to get everybody that's eligible for a thrombectomy into the thrombectomy suite and proceed with the thrombectomy as soon as possible. So this is why during an LVO code, obviously things are moving very fast. Similarly, it's basically, similar to, when we have a patient that's herniating that needs to go into the OR for emergent surgery, same type of thing with the thrombectomy. It's just as critical, basically. And you can see here, that basically this is a CAT scan of a person with a stroke, and you don't really need to see any large stroke yet. It's even hard to see if there's ischemic changes yet, whereas down here, this one in the bottom left here, you can see this area of the left temporal and frontal lobe that's already developing an infarct there. So, the longer time, the more irreversible the injury is. And I guess actually what he was also pointing out is that different patients are very different. So you might have some patients that don't progress rapidly, and it can take some time, and then some people that do progress rapidly. So while longer time generally will result in less good outcomes, you can have patients that even a short amount of time can have irreversible injury, and conversely, some that take longer to have that. So you can have slow progressors and you can have fast progressors. And that's really a function of how good the collateral circulation in the brain is in those particular individuals. So in a normal case, where you say had the watershed area between the ACA and the MCA territories, so on the basically on the cortex surface, the cortical surface between where those two distributions are. You'll have some anastomoses between those. They're not completely 100% end arteries, but those anastomoses are not super robust in a lot of people, or they might be in some areas of the brain in one person, and then another area of the brain in that same person are not as robust. You can have a patient that has very has less anastomoses, and so has very poor collaterals. And if that patient then gets an LVO, say in the MCA here, and they have no flow past that, the collaterals from the MCA can't really compensate because, again, they have, poor anastomoses in this particular area of the brain, and therefore they're going to end up with a very large a reasonably large infarct in a short amount of time because they're not getting any perfusion help from the ACAs. Conversely, somebody with good collaterals, and oftentimes, kind of paradoxically, patients with good collaterals are patients that have kind of had more kind of long-standing ischemic issues potentially where they've developed collaterals over time, although they could have also more atherosclerotic disease, so those collaterals may be kind of still prone to clotting off themselves. But what can happen is you get a situation where you would have the same clot, say in the MCAs, but because they have better collateral flow, the area of injury, or the area of like where the infarct kind of progresses quickly, is much smaller, and then there's this area around it that is still receiving some flow, not as good as it was before, but enough still to survive where it hasn't been irreversibly injured, and that's the penumbra. And so that's the area where it hasn't been irreversibly injured yet, but if it keeps on going on long enough, that area is potentially going to be irreversibly injured. And so the area of irreversible injury that has already occurred is relatively small, but this area is at risk. So in this patient might be a slow progressor, but this patient also has can receive a benefit from getting this clot out, because if they don't get the clot out, this will eventually infarct, but there's still some time to get that clot out and preserve this area of the brain and salvage the area of the brain that's the penumbra. Whereas in this patient, it may already have progressed to an irreversible infarct by the time they get to the hospital. So that brings us to the third T, which is target, which is how do we select patients to determine whether or not they're a good candidate for thrombectomy. So the first thing is, obviously, we want to find out, do they have an LVO at all versus a lacunar stroke, or is there altered mental status and their stroke symptomatology from some other cause. So we always want, if somebody comes in and we do a stroke code, they're going to get a CT angiogram because the CTA is a very high sensitivity to determine whether or not an LVO is present. We also use technology called Viz.AI, which is artificial intelligence, that basically all the CTAs in the hospital are sent through this, and if there is, it will look to see if there seems to be a large vessel occlusion on the CTA or not. And the reason why we have all of the CTAs in the hospital is we used to just send in the ones that were stroke codes, and then we actually had a trauma patient that got a CTA that had an LVO, and it wasn't picked up as quickly because everybody was concerned about the trauma. It did get picked up like an hour, maybe later, but we could have cut some of that time off if it had been going through Viz.AI, because Viz.AI would have detected and alerted us. And so now, after that case, we actually switched to having all CTAs, regardless of the reason why we're getting it, go through Viz.AI so that it can alert us if there is a large vessel occlusion, particularly on patients we weren't expecting it maybe. So this should pick up, an LVO in the ICA terminus, M1, M2, maybe M3, A1, A2, basilar artery. The other thing we want to look at is the non-con CT scan, because this is going to determine how severe and how irreversible potentially the injury already is. And so really the ideal patient is a patient, again, like this patient, where you either don't have an area of irreversible injury yet, or the area of irreversible injury is already quite small, and that you have an area, but you have an area that is at risk for irreversible injury still. So you want to show that the established damage is not that severe. And so a CT scan can help you with that. And really what they're using is the Alberta, the aspect score, which is the Alberta a score developed out of the University of Calgary in Alberta that looks at different locations in the brain. Basically, you're looking at basal ganglia, caudate, different things like that. And everybody starts off with 10 points, meaning 10 points. There's no hypodensities in any of those areas. And essentially, each of those areas that has a hypodensity, or an area that you can actually see on the CT scan, has either a significant ischemia or infarcted, you decrease a point. And so you want, and basically, so if you have somebody that has an aspects of 4, that means 6 of those locations they have hypodensities in, and which means that they have a pretty significant area of the brain that is likely irreversibly injured already. And so that's kind of like the core infarct area. You don't want that area to be too large. So if it is too large, then those patients have not only one less likelihood that removing the thrombus is going to reverse the injury in those areas that's already occurred, but two, those patients are at a higher risk of hemorrhage. And so we typically want the aspects to be greater than or equal to 6. So in other words, they have a relatively small area of infarct already. They may have a large area that's at risk, but there isn't like a massive infarct that's already occurred, essentially. Conversely, though, you also want the patient's symptoms to be severe enough. In other words, we don't want to be doing thrombectomies, which do have, as an invasive procedure and has some risk associated with it. You won't want to be doing it on patients that don't have necessarily a significant symptomatology associated with that, because that usually means that they have significantly preserved collaterals and despite the presence maybe of an LVO or it's not super rare that you see like an LVO that doesn't have pretty bad symptoms, but you can see, maybe like an A2 or an A3 or something like that is occluded where they're not. And that's usually because they have good enough collaterals that they are compensating for that. And then so, those are the types of patients that we would want to kind of put on like an LVO watch and admit and watch very closely, because if they start to have symptoms and their NIH stroke scale starts to go up and go up to 6 or above, then that's somebody then would qualify for a thrombectomy. So typically the cutoff they use right now is an NIH stroke scale of 6 or more to determine that they're ineligible to go for thrombectomy. Importantly, there is no limit on age, so they don't preclude, if somebody came in theoretically and was like 110 years old, if they met all the other criteria, they would still take them for a thrombectomy. So age is not important in determining who is a candidate or not. What is important is their baseline functional status, and so they really kind of reserve in the most cases thrombectomy for those patients with a modified Rankin score of 0 to 2, which that means basically they were independent in the home. They may have had some deficits, they may have had some disability, but they were largely independent in the home. The reason for this is that, basically, as I showed before, it takes 2.5 patients to move somebody from the kind of dependent disability part of the Rankin scale to the non-dependent Rankin scale portion of the Rankin scale in patients that had LVOs. And so if you already are starting off dependent, right, you're not going to get better than that after you've had a stroke and now and had a thrombectomy. So it's really, we're trying to preserve function in patients that had function to begin with. And so there's much less benefit to doing a thrombectomy in somebody that's obviously disabled. Now, you could make the argument that, like somebody that has a ICA occlusion, that it was going to die from that potentially, that it was like a Rankin 3 or 4, you could potentially do it in terms of like, I guess, like heroic measures in those cases, but it's not the typical kind of person they would consider a candidate unless it's like kind of the last ditch option, really. So really trying to target those patients that are functionally independent at the home. And then in terms of time, so the ideal time is 0 to 6 hours from symptom onset. So if they have a symptom onset at noon, by 6 p.m., you're trying to have them not only in the angio suite and have the thrombectomy and reperfused all during those 6 hours. That's what you're trying to do. However, the time frame, like, we used not to do these later thrombectomies, but now what they've been shown is basically like even in patients up to 24 hours, they can still potentially have a benefit from thrombectomy, but it does require additional information to determine and to make sure that they haven't infarcted more of their brain, that they still have an area of penumbra, so they still have an area of reversible injury, and that it isn't all irreversible by that time. And so what we will usually get then in patients in this time frame is we will also get a CT perfusion, because the CT perfusion, that along with the CTA and the CT scan. So the CT scan with the aspects, it's kind of a crude and dirty way of like figuring that out, but a CTP is much more sophisticated with that. And so once it's past 6 hours, we will routinely get a CTP to help decide and see, okay, is like the area where the core infarct, is that still surrounded by a pretty significant area of decreased perfusion, but not irreversibly injured brain. And if so, then that's somebody that would probably benefit from a thrombectomy and that would go versus somebody where you'll see like the core infarct and you don't really see an area of decreased perfusion significantly around it. That's somebody where, that the area that was injured from the stroke is basically irreversibly injured and there's really not an area of risk of brain around it. And so that patient's probably not going to benefit from a thrombectomy as much. So that's where that kind of helps us decide. Um, so this is just a run of somebody that has an M1 occlusion over here on the left side. This is a lateral projection here, so it's a little bit hard to see, but this is the occlusion there. This is just a schematic that Dr. Tor has of them putting the guide wire through the clot and then putting a stent retriever, opening it up and expanding it. They put it so that the end of it is a little bit past the clot, and they open up and this will start to trap the clot, and then they can pull the whole clot out together all as one piece basically. It's a stent retriever. So Dr. Shore would be able to talk a little bit more elegantly about the actual procedure, but this is what it looks like when they get this out. And then you can set, and then they'll do, some additional angiogram runs to make sure that see how the perfusion is looking distal to that. So this is a case where they had they did like needed 2 passes, but they eventually got a TICI 3 result. So often after 1 pass, they might do another angiogram and see that there's still a little bit of thrombus there, or sometimes vasospasm, and need to open that up a little bit. And so they might need to do another pass with that. And then obviously they're also looking to make sure there's no area of injury to the blood vessel, that everything looks good. And so this was groin puncture to recanalization, took 49 minutes. I'm not sure what this graph is looking at, but yeah. So in terms of system reorganization, so basically as stroke centers have started to become more organized, there's been different ways to kind of organize large systems around a spoken hub model. So kind of the older model was that you might have like a hub, like a comprehensive stroke center, a spoke hospital, like a thrombectomy center potentially, or maybe just a primary stroke center, I guess, primary stroke center. And you would take the patient, they would go to primary stroke center, and they would go from there to the comprehensive stroke center. That was called the drip and ship method. But you can imagine like each of these transfer points, it takes excess time every time. Every time you like stop somewhere and then go to another place, it maybe takes a couple of hours, right? So it might take a few hours before you get to the hub. Another one was bypassing the spoke hospital altogether, so don't even stop at the primary stroke center, goes all the way to the hub to get your thrombectomy. But again, this might be a relatively long travel time, potentially to go all the way from here to there. So particularly in a place like New York, we use this system where this works quite well, where instead the spoke hospital, like here, it has thrombectomy capabilities. So instead of having the patient go all the way to the hub, all the way, say, into Manhattan to get their thrombectomy, the EMS brings them here, and then the team comes from the hub to here. So what that does is that decreases the time, theoretically, and if it was an even amount, like in half, because now the patient only has to go from here, and then the team is meeting them here, and so it really reduces the amount of time it takes for the patient to get to somewhere where they can do a thrombectomy. So in terms of kind of switching to more pragmatic discussion about the care of the potential thrombectomy patient in the ED. So the objective when the patient is in the ED, the objective of our team when we go down to an LVO code, and so, we made the decision long ago that, because the neuroendovascular team is, it's part of the neurosurgery team, and we treat this as an emergent neurosurgical intervention, just like any other emergency neurosurgical intervention, that our team needs to go down anytime there's an LVO code, because the chances, it's not always going to be somebody that ends up needing a thrombectomy, but it's a very high likelihood. And so the objective during the ED phase is to acquire brief data, rapid assessment of the patient's stability. So we want to know when the patient was last unwell. So this gives us kind of our time frame of, are they in that 0 to 6 hour window? Is it more than 6 hours? basic vitals, one other glucose. Might need to put them on a cardiac monitor, particularly if they've had syncope or have a pre-existing cardiac disease. We want to get a rapid neurological assessment, and then we want to get them into the CT scan and get a CT and a CTA rapidly. So we can see if there's an LVO, we can calculate their aspects, and if it's been more than 6 hours, we also want to get a CT perfusion. So some of the things we want to calculate, usually one is the SLAMs. Usually that has been calculated by EMS before they get to us, but we'll want to make sure we know what this is, and this stands for speech, and then the LA motor scale or motor score, and there's another slide that goes over that a little bit, NIH stroke scale, and then cortical signs as well. So in terms of SLAMs, it's basically the LA motor scale, which is facial droop, whether it's absent or present, arm drift, whether it's absent or whether the arm drifts down or falls rapidly, and then grip strength, and then speech, which is also denoted as 0, 1, 0 being normal, 1 being abnormal. And then basically a 4 or above is considered highly likely that they have an LVO. So that's, typically done by EMS. And basically, if somebody gets picked up in an ambulance and they calculate a SLAM score of 4 or above, they will alert the hospital that they're bringing them to that this is a potential LVO. And so that's called pre-notification. That helps us when we do get that, then basically they will alert the stroke team and our team and page us so that we're basically down there when the patient arrives, and similar to what happens in like trauma cases where they pre-alert us. But because New York, because the travel times are very short typically compared to other places, we don't always get pre-notification. A lot of times they are arriving before we've even gotten the notification from them. In terms of timing, kind of what we want to try and do is get the patient into a CT scan in less than 20 minutes. Once they've gotten the CT scan and we determine whether or not they're eligible, whether or not they have a stroke, whether or not they're going to have a LVO, we also want to get them either TPA or now we use tenecteplase or tenecteplase if they're eligible for that. So typically, if they are, we want to, there's different time kind of time gradations here, but we want to get it in as fast as possible. But the way the Joint Commission and kind of the get with the AHA get with the guidelines is you want to try and have at least 85% getting it in under 60 minutes, at least 75% getting it in under 45 minutes, and at least 50% getting it under 30 minutes. But ideally, I mean, in an ideal world, you'd have all 100% in under 30 minutes, but that's almost not possible because people are arriving at different times. But this is kind of what you want to try and do. And then in terms of door to groin puncture, I'm not sure if I think these are door to first pass that he wants, but we're really looking to try and get so somebody is going to get a thrombectomy after they might skip the TPA point if everything is ready and they can just get them straight on the table and get them to the thrombectomy. But if they're able to get them the TPA beforehand, then they will start giving the TPA, and then they'll get into the thrombectomy suite. Thrombectomy started, get the groin puncture going, and then the first pass, they really want to try and have less than 90 minutes for walk-ins and less than 60 minutes for transfers. So the reason why it's shorter for transfers is because for transfers, we should have basically a pre-notification and know they're coming and be aware the patient should be able to have a bunch of stuff kind of ready. And so it shouldn't take as long for a patient being transferred to us that we know about to get to this point. Whereas somebody that's a walk-in, or really what this also refers to is like EMS dropping somebody off where we had no pre-notification, it takes a little bit longer because there's additional information that you may need to get that you haven't kind of prepared yet for their arrival. So it's 90 minutes, less than 90 minutes for walk-in. I'm sure most of you have seen the angio suite. This is not our exact angio suite, but this is the system we have, which is the Miyabi suite, where it has the Siemens, where it has the both the biplane and the CT scanner in the same room. So care of the thrombectomy patient in the angio suite, we have kind of like 4 different things: station, sedation, medication, monitoring. So station is a time-sensitive step. There are limited resources and multiple needs. There's multiple things going on. So everybody needs to collaborate together and prioritize different tasks. We need to make sure that the patient is positioned on the table. We need to make sure they get arm restraints, especially if they're aphasic or agitated or non-intubated patients. Need to fix the head so that the head's going to stay still during the procedure. And then if it hasn't been placed yet, placing a Foley catheter in the patient. So sedation, ideally, they try not to use general anesthesia if they can avoid it, and use moderate sedation as much as possible. We do have anesthesia there in case they do need to be intubated. Intubation obviously in many cases takes more time. You have to, there's multiple steps you need to go through to intubate the patient. And then we also lose the neurological exam for a little while. So when possible, they try not to do it with intubating patients, but sometimes you need to, particularly in a more severe stroke. Medication, there are several medications that are important in these procedures, both during and after the procedure, and before the procedure. So one is blood pressure control, right? In any neuro patient, and in particular stroke, blood pressure management is probably one of the single most important things in managing these patients. And it's not, it's more critical than it is in almost any other disease process. So, when we give parameters for blood pressure, we really want them to maintain those parameters. It's not a suggestion to do like 100 to 140, where like 150 is acceptable or 160 is acceptable. It really needs to be kept in that range, because you're trying to balance the risk of causing them to become ischemic and have too little blood to the brain and then have a stroke despite all your best efforts, versus the risk of hemorrhage, which after a thrombectomy is actually higher than it was before. And so you don't want to allow their blood pressure to just go off the rails and be super high, and then they have hemorrhagic complications. So we do want to make sure we're managing patients appropriately, blood pressure management. And so usually that in any kind of neurological emergency, that means using IV infusions initially to make sure the blood pressure is controlled. So that's, clevidipine, Cleviprex, kind of in the immediate setting. And if we need to keep on using IV infusions, probably switching that to Cardine after a couple hours. If Clevi is still needed for a couple hours or more, switching that to Cardine. And then switching it to like oral medications like oral labetalol or IV labetalol or something like that. If later when we're trying to get them off of the IV infusions, but initially, really in the acute term, it really almost always should be IV infusions. You don't really want to be giving IV pushes of stuff, except for maybe very temporarily while you're getting the infusion set up and going. But really, the goal should always be to get an infusion going, because that's going to be the best way to titrate the blood pressure medication on like a moment-to-moment basis to make sure they stay in that range. Obviously, they use different antiplatelets to prevent rethrombosis. Aspirin, as we know, Plavix. There's also Prasugrel, Effient, and Brilinta with varying strengths. Only one that we can give them rectally is aspirin. In terms of intravenous antiplatelets, there's Integralin, ReaPro, Cangalor. Anticoagulants, particularly if they have like heparin, if they have to either do a radial access, or if you need to place a stent or something like that, you might need to have to use heparin so as well. And obviously the antiplatelets you'll need if they end up having to leave a stent. It's not usual in a lot of thrombectomies. They don't need to leave a stent, but they might if it's continuing like reoccluding, or there's significant like atherosclerotic disease that makes it critically stenotic. They might need to leave a stent in that situation. In terms of vasospasm, so again, a lot of the times, because they're manipulating the vessels and they're going up the catheter, and anytime, a vessel is subjected to any sort of unusual circumstance or manipulation, they can spasm, and both at the site of where the thrombectomy is and potentially distally as well. So they often have to give, or they might have to give medications to Reverse vasospasm, these typically are calcium channel blockers, so verapamil or nimodipine. Um, so recently, in the last few years, more and more, they've been using the radial access method. The traditional way of accessing the um, vasculature is through the femoral artery, but oftentimes they can use the radial artery. Um, the radial artery, there are some benefits to this, particularly in some older patients. But the radial access does have one of the issues with radial access is it's prone to kind of vasospasm or occluding because it's a very small. So often they'll have to give heparin, um, nitroglycerin, verapamil. And so one of the other advantages of radial stick is you can't get like a retroperitoneal hematoma or anything like that from that. There are potential other complications from it, but typically less severe than femoral artery puncture. So if you're like anticoagulated, things like that, it can be safer. Um, So monitoring, they will be monitoring vital signs Q 15 minutes and using continuous cardiac monitoring with the anesthesia team. Oftentimes, neurological monitoring. So getting a serial neurological exams during the procedure is deferred, unless for some reason the MD requests it. So that might be, if they see something on the angiogram, like extravasation or something that looks like, there might be hemorrhage and the patient is not under general anesthesia, they might try and see if their neurological exam is still consistent with what it was at the beginning of the procedure. But a lot of times they're waiting until the end of the procedure to get another assessment. And then monitoring of the distal vascular circulation, either pulse oximetry on the thumb or toe is used to make sure that they're still getting adequate perfusion into the extremity distal to where the puncture site is for the thrombectomy. So I mentioned blood pressure targets before. This is a big takeaway from the lecture. So the blood pressure targets before and during the procedure are different than they are after the procedure. So in somebody that is getting TPA or tenecteplase, so if you're getting thrombolytics, we want your blood pressure to be less than 180 over 105, and that's to reduce the risk of hemorrhage. So we try and get patients down under this because if they are higher than this, then there's a higher risk of hemorrhage when you give them the thrombolytics. We're not trying to necessarily get their blood pressure down to 120 or 130 because they haven't been recanalized yet, and so that could accentuate their stroke. If they are not a candidate for TPA or tenecteplase, then typically we'll allow their blood pressure to be a little bit higher to make sure that they are still perfusing as much as possible. And because they're not getting the thrombolytics, their risk of hemorrhage is going to be a little bit lower. So you can allow their blood pressure to be a little bit higher, so less than 210 over 110. Now, after they recanalize, so after you've, say, done a thrombectomy on them and you successfully reperfuse them, so they're TICI 2B or TICI 3, you want to decrease their blood pressure down and control their blood pressure very tightly in a lower range because now all of a sudden that area of the brain distal to where the thrombus was is now being reperfused, but that area of the brain is no longer necessarily 100% normal. That area of the brain has, even if there isn't a permanent infarct that we can see on an MRI or a CAT scan, that area of the brain has been injured already to some extent. There's areas of the brain that have been starved of oxygen and blood for a significant period of time, and the blood vessels as well in those areas may not be normal. They also may be like impaired autoregulation in those blood vessels, so their ability to respond to wild swings of blood pressure is going to be impaired, and they have an increased rate of hemorrhage, basically. So typically after we reperfuse them, we want to keep their systolic in the 100 to 140 range. So this says less than 140, but you also want a bottom level. So that's the other thing is, whenever you're putting in blood pressure parameters in Epic, we always need a lower level and an upper level for the blood pressure parameters. So usually we'll do like 100 to 140 after somebody's been reperfused to make sure it's not too low, so they're not becoming ischemic again. But we definitely don't want it too high either because that'll increase the risk of hemorrhage. So, we want it less like 100 to 140. If the reperfusion is not successful, so say it's like a TICI, 0 to 2A, 0 to 1, not much perfusion past where the thrombus had been, then they'll let their blood pressure be higher because you are going to need more pressure to continue to perfuse that area of the brain past the area of the occlusion. So usually they'll do less than 180. So you might see them do like 120 to 180 or 140 to 180 in this case. So closure of the puncture site. So manual compression is still kind of the old school way. Now they use a lot of closure devices, but there are still times when you have to do manual compression. You have to do 15 to 20 minutes really of manual compression um, to close the puncture site. And I know Dr. Shore and the cerebrovascular folks will show our PAs, those that haven't been shown how to do manual compression, or one of the other PAs will show them. But basically, you want to find where the puncture site is, and typically, if it's like the femoral artery, for instance, you know, the direction that they are putting the needle into the femoral artery is from inferior to superior. So actually, the puncture site in the actual artery is actually above where the puncture site in the skin is. It's usually, a centimeter or two above that. So usually, what we were always taught was if you take your hand and you put your index finger, say, say your right, say it was like the person's this left femoral artery. If you take your right hand and you put your index finger basically where on the puncture site in the skin, and then you use the next three fingers, you basically want to be pushing down with the kind of like your upper two fingers more than your index finger, because those are going to be the ones that are actually over the puncture site in the artery. So you kind of press down with all three, but just be aware that the puncture site in the artery is actually above um, where the puncture site in the skin is. And similarly, kind of with the radial artery, that's usually the case. It's going to be like a little bit a centimeter above the puncture site of the skin. And you can kind of see that from this schematic, right? This is a closure device, but you can see that if this was the artery, the puncture site in the skin is not going to be exactly over the puncture site in the artery. So they're now used different closure devices. There's all sorts of different ones now, but this is one that usually these go over the guide wire, and they might have like a thing. I think this one's like a balloon with like a little kind of plug that sits on the inside of um, or I guess yeah, inside of the artery. Other ones that are kind of more like a suture style one that helps close it. Uh, and then for the radial artery, we use the TR band, which is a radial compression device, which allows you to set this and then come back and check on it every now and then basically then sequentially lower the pressure in it uh, eh, while as time goes on, and then take it off when the hemostasis has been achieved. But that allows you to not have to sit there and hold pressure on the radial artery for 20 minutes or so. And I know I think they've trained many of our PAs to do this and done in-services on this. So if you need still training or in-servicing on the TR band, let me or Dr. Salgado or Magda know, and they can arrange for you to get trained on it as well. So in the post-thrombectomy period, there are several important things to keep in mind. One is the disposition, where is the patient going? Um, vital sign checks, neuro checks, what the bed position should be for the patient, vascular checks, so checking, the distal extremities and the pulses, and the puncture site checks. So those are all important things. So disposition, so typically, post-thrombectomy patients are ICU level status patients, and so they're going to go to the SICU, and if there is no SICU bed available, they would go to the PACU. So when they do go to the SICU, they're still, in either case, they're going to be on the neurosurgery team with us as the primary team until they are no longer ICU level and physically out of the ICU. So they'll stay on our service while they're physically in the ICU. And then once they leave the ICU, they will typically be transferred to the stroke team in the stroke unit. While they're there, they're going to have usually 1 to 2 nursing, and this is because they need to be, frequently monitored, both for, neuro checks, puncture site checks, as we said, vascular checks, and whatnot. So, Eventually, when we have dedicated neuro ICU beds on E7, which is hopefully going to be in, a year maybe, those will be basically dedicated for cerebrovascular patients initially, and primarily. So that's where the LVOs will primarily go. But they're, if those were all filled, then the next place they would go would be the STICU. So um, so bed position. So one of the reasons that closure devices are very helpful is not only do you not have to keep pressure for 20 minutes, but you don't need to keep the patient's bed position flat as long. So typically, if you have a closure device, say in the femoral artery, it's also one of the advantages of the radial artery, right? Puncture is that you don't need to worry about keeping their head of the bed flat. You can sit them up right away, which is potentially helpful, particularly if they're at aspiration risk, or they have respiratory issues, to be able to have their head up sooner rather than later. But if you have a closure device, bed needs to be completely flat for 2 hours, then gradually elevate the head of the bed. Now, I mean, one of the things you can do is obviously if somebody's an aspiration risk or respiratory risk and they need to have the head of the bed up, and it wasn't done radially, and maybe say you didn't use a closure device, you can still elevate their head of the bed. You just need to do reverse Trendelenburg. What this really means is that um, in the case of a femoral puncture, you don't want them bending at the hip, because that can potentially dislodge the clot and open up the puncture site and then develop a hematoma. So if there's no closure device, you really want that their hip flat for 6 hours. And so what we say is like, keep the bed flat for 6 hours. You can use reverse Trendelenburg potentially to elevate them a little bit, but you can only get so much, through reverse Trendelenburg. But that's one way you could raise the head if you needed to. But if you do use a closure device, it only needs to be 2 hours. Basically, vital signs, neuro checks, vascular checks, puncture site checks kind of follow the same schematic, which is Q 15 minutes for 2 hours, Q 30 minutes for 6 hours, then Q 1 hour for 16 hours, for a total of 24 hours. Obviously, vital signs and neuro checks are going to go longer than 24 hours. After 24 hours, you can usually stop vascular checks and puncture site checks, although we will do puncture site checks every shift still, and vascular checks usually every shift for a couple days just to make sure. But vital signs and neuro checks, as long as they're in the ICU, are going to stay usually around Q1 hours or so. We kind of talked about this already, but hypertension can result in reperfusion hemorrhage, so you really want to make sure the patients are hypertensive. Hypotensive could be a sign of hemorrhage. It also could potentiate ischemia in the brain, so we don't want them to become hypotensive. If they're tachycardic, that may be a sign of them having either pain or hemorrhage or hypovolemia for some reason. Neurochecks, the reason why we're, particularly in the first 24 hours after a thrombectomy, those are the highest chances for hemorrhagic conversion, so we want to be on the lookout for that, or a reocclusion or a recurrent stroke. Patients can also potentially be at risk for seizures. We always want to get a baseline assessment right after the thrombectomy, including the NIH stroke scale. So, this applies to, the huddle now applies to any patient coming to the SICU. So any patient that is arriving in the SICU from any other area, whether it's the ED, the PACU, the OR, the angio suite, there's a huddle between the surgical team and the ICU team to go over, the patient's exam, what the intervention was, what, orders need to be placed, and what orders have already been placed, and then what the plan is. And we do that as well for the thrombectomy patients. And then there's obviously any change in anything, neurological status or blood pressure or things like that, we need to be notified. So in terms of vascular checks, it depends on what extremity and what the access site was as to what you're going to check. If it was the femoral artery, then you want to check the popliteal pulse, posterior tibial, dorsalis pedis. Typically we'll be looking at the dorsalis pedis a lot of the time, but you can use posterior tibial or popliteal if you need to. Radial, you want to be checking the radial pulse. If it can't be palpated, then use a bedside Doppler, and then it's often very helpful to mark with a marking pen, one of the OR pens that's washable is ideal for this, but mark where the pulse is so that you can, one, it makes it easier to feel for it if you can be palpated, but then two, if you need to use the Doppler, you know where to go with the Doppler as well. Signs of limb ischemia include color change, temperature change. You can use pulse oximetry just like they did during the actual thrombectomy and put like a pulse oximeter on the toe potentially that can help. If there are changes in these things, that's a potential emergency. So if there's, no palpable pulse and it can't be Dopplered, and then there's signs of ischemia in the foot, so this picture here shows this left foot or right foot, patient's right foot being dusky and blue. So that's somebody that, that would be a potential emergency to, assess whether or not that patient had a an occlusion of the artery somewhere, and then potentially need a vascular recanalization of that. So, the patient would probably get a CTA of the limb and then an angiogram potentially. Um, so just keep that in mind that those, if you see that or the nurse reports any of that, that's something that needs to go up to the attending level very rapidly because it might need to be intervened upon. Similarly, puncture sites, if there's issues with the puncture site, that should be relayed to the attending rapidly as well. So different potential complications include oozing, rebleeding, hematoma, infection. Infection was pretty rare. Oozing is usually because of bleeding from tissue capillaries, and really the treatment for that is holding pressure. Sometimes we can use topical hemostatic agents. Rebleedings when there's really like a reopening of the puncture site, and there's often either external or internal sides of hemorrhage. So this is usually when you see like a pretty big hematoma that is like increasing in size. That's obviously needs to be addressed with the attending rapidly. If it's excessive, you can get changes in vital signs. Again, well, at least the initial treatment is to hold pressure, often 20, 30 minutes, and make sure the attending is aware as well. So these are just kind of a little bit of overview of the workflow. So again, we're always responding to the LVO codes in person. The next thing that needs to happen is to place orders for IR thrombectomy and obtain consent as rapidly as possible, so that the patient can get on the table and get the groin puncture and then get the angiogram or then thrombectomy started. At some point in the future, we may be credentialing PAs eventually to do the groin puncture. So I know Dr. Shora has been he would like, well, that's one way that we can potentially decrease the time to recanalization, is that as the thrombectomy team is still en route, if a patient is a go for a thrombectomy and they can get on the table, and the fellow and the attending have still not arrived, that and everything is otherwise ready, it may be the situation where we could then have somebody that has been trained to get access and get the sheath in at some point. I think that there's some issues in terms of supervision and credentialing to allow that to happen, and so I don't foresee that happening immediately. I think that I think right now that the fellows can get groin puncture without the attending being there, and I think that is probably where it's going to stay for the time being. But I know there in some places around the country, PAs do that, and so if it's possible, we might at some point move that way as well. Post thrombectomy. So I just want to, this is probably one of the more important areas to make sure that everybody's clear on, is that what we want, similar to when we have patients in the OR that are going to the SICU or that are ICU or to the ICU status afterwards, we want to make sure that we're placing all the orders that we want for these patients before they leave the thrombectomy suite or before they leave the OR back to the ICU in a surgical case we do. So when the patient goes to the PACU, we're ultimately responsible for putting in all the orders. And then when a patient goes to the SICU will put in orders as well often, but we need to make sure that all those orders are correct. And so one of the best ways to do that is to put in all the orders before they get there. And so particularly with the thrombectomy patients, as I said, in patients that we operate in the OR, it's just good habit to put in all of those before they even leave. And then, if the SICU needs to DC and reorder something, they can. but everything at least then that we want will be ordered. And so for the post-thrombectomy patients, there's no one order set that includes everything, unfortunately. So you need to use the first thing you need to do, it's not really on here, is you should just discontinue all the previous orders. Discontinue everything that is already there. Because there will be, if you don't, there's going to be a lot of duplicates. There's going to be, there's going to be the pre-TPA or the pre-thrombectomy blood pressure orders that are going to be in there. And those are going to be different parameters than what we want afterwards. So you need to make sure, the easiest thing is just to DC everything and start with a fresh slate and then use the post-thrombectomy order set and put that in, realizing that that only includes like the vital signs and the vascular checks and things like that. Based upon this kind of schematic that we sent here. And it doesn't include a lot of other things that we need to put in. First of all, it stops all the vital signs and neuro checks after 24 hours. And so you really want to make sure that you edit those and you change those so that those are going to go for a full 14 days. You also want to make sure that we put in any other IC orders that we typically have, like ins and outs and different things that we want. I did put together a Google Drive. There's a Google Documents on Google Drive that's like a list of all the orders and stuff, and it doesn't include all the disease processes yet, but it does include thrombectomy and includes like all the orders that should be put in for a post-thrombectomy patient. I'll pull that up after we finish going through this. And really, probably most critical is you want to make sure that there is a clinical alarms order that has the blood pressure parameters as well, that has the specific blood pressure parameters that you want post-thrombectomy, and that needs to be confirmed with either the fellow or the attending what blood pressure they want. And then in addition to that, there needs to be an order for either clovetapine or nicardipine with the same blood pressure parameters. And the reason why we want that order in before they even leave the thrombectomy is that not only should they have the order in, but anesthesia is really supposed to get it, or if they don't have it, the SICU is supposed to get it. So that basically there's almost like a very minimal time period, or essentially ideally no time period, where there isn't clovetapine or nicardipine available to be started to infuse into the patient to make sure their blood pressure is staying in the area that we want. Because what we want to avoid is a situation where they leave the thrombectomy suite, go to the SICU, and then there's still like a 20-minute period in the SICU where they're putting the order in for the clovetapine, waiting for the clovetapine, and then giving like labetalol pushes or something like that. We want to avoid that. So it's even if it means they don't leave the thrombectomy suite for 15 extra minutes and it takes that period of time to get the order in and get the clevy there and get set up, that's better because anesthesia is there. Anesthesia is able to give them stuff. It's a little bit more tightly controlled. So we want to make sure we're putting in the order for the clovetapine and nicardipine and really getting the medication there and set up so that by the time when they get to the SICU, that's already all there. And then there'll be, the huddle once they get to the SICU. And as part of that huddle, it's very important to make sure that the chief neurosurgery resident on knows, and both the on-call neurosurgery attending knows, as well as Dr. Capinos if Dr. Capinos is on. So kind of the way, oftentimes, a thrombectomy comes in and say it's like Dr. Caton is the attending, the neurosurgery chief resident may know, but they also, because they're on the cerebrovascular thing, but the neurosurgery attending on call might be doing something else and may not be aware that there is a thrombectomy that is going on. So it's always good to make sure, ideally, even before the thrombectomy is done, it's good to make sure that the neurosurgery attending on call is aware that there's a thrombectomy happening. But at the very least, once the thrombectomy is done, the neurosurgery attending on call is going to be helping take care of that patient, so they need to be made aware. The chief resident needs to be aware. And if Dr. Capinos is on, he's actually going to be the attending of record. So if Dr. Capinos is on, he'll be the attending of record when they're in the ICU. If he's not on, it'll be the neurosurgery attending on call. But both of them need to be aware, or at least the neurosurgery attending always needs to be aware, because if that patient ends up having a hemorrhage or swelling then, or needs an EVD or something like that, they're going to need to be involved in helping manage that as well. So it's always a neurosurgery attending that needs to be aware, and then plus or minus Dr. Capinos, depending on if he's on or not. And so then, the other thing is making sure that we keep the communication open. These patients have a lot of different services involved, and so it's very important that we're always communicating between the different services. You know, that includes neurocritical care and neurosurgery, the neuroendovascular teams. We always want to make sure that anything that's going on with the patient afterwards, that we're also communicating it back to the neuroendovascular attending in case they want to do something different. And then also the stroke team as well, and the ICU team. So multiple different teams. So we always have to make sure that we're communicating as best as possible with everybody. This is a little bit outdated because there's a few team members that have joined since then. But these are all the members of the cerebrovascular team. Dr. Oxley is no longer covering call here because he's so busy with Synchron and the brain-machine interface technology. So he's no longer covering call. But in addition to these 8 folks, Dr. Caton, we need to get a picture for him. And then Dr. Majidio as well. And then Dr. Goldman is going to be joining us starting in next month, actually, as well. So Dr. Darrell Goldman, she's one of the fellows right now. She'll be joining us and attending as well. And we'll be starting covering call as well and covering here at Elmhurst as well for emergencies. So that's it. I will just pull up, if I can find it, the orders. So yeah, if you go here, again, I don't have it for everything yet, and you should be able to just click on the bookmark. Yeah, so post-thrombectomy. So again, just going back to the front, you know, this is very useful because the order sets, unfortunately, one of the issues with the order sets throughout H&H is that in order to edit them or fix them or change them or insert anything into them that's not already there, requires basically like all the hospitals to agree essentially. So in other words, to change anything from the thrombectomy order set requires all the thrombectomy centers to agree to those changes for the most part. Similarly, for like to change any of the neurosurgery order sets requires all the neurosurgery services in 5 different hospitals to agree to do it. Because basically locally we don't have the ability to change it. We have the ability to save our own order set preferences, but that doesn't solve the problem that if there's things missing from the order set that are not in there or a different order that you would rather use than the order they have in there, you can't change that. All you can do is tweak the orders that are in there and save your kind of preferences. So this helps with kind of at least the stopgap way of at least indicating all the things we need to do that the order set really doesn't take care of. So first is discontinuing all the orders, putting in an admission order. Ideally, this would be in before so that they can start working on it, so that bed board knows and they can start working on this. I mean, this should actually be in before they, you know, when they're getting on the table for the thrombectomy, that's the time to kind of put in the admission order. Or I think you might even need it in before you put the thrombectomy order in. I'm not sure, but around that same time. Use the post-thrombectomy order set to place specific post-thrombectomy orders. They often need to be edited in terms of like the actual like frequencies, things like that. Again, vital signs, neurosets, they would default to 16 hours actually, so make sure to change it to 14 days. The last one, the Q1 hours. Same with the neurochecks. Strict I's and O's. Clinical alarm, notify provider order. That's probably one of the single most important orders because that's where the blood pressure parameter orders as well as everything else should be. Additionally, you know, order any vasoactive medications, as I mentioned, clofazimine or nicardipine with the same parameters. Make sure they are ordered to be NPO. And the other caveat to that is there should be no PO medication orders. The Joint Commission actually views that as like a citation, so you really want to try and avoid that. But basically, just the easiest thing to remember is MPO and no SIPs with meds, just straight MPO with no order for any PO meds until they get either a bedside dysphagia screened by the nurse or the neurology team will also do it and it's documented that they've passed, or they get a formal SLP eval. And it basically, once they have to have passed and had the documentation in the chart that they passed, and then you can order PO meds at that point. And then there's just other kind of like the routine orders that you need. So most of them are kind of self-explanatory. All right. Anybody have any questions? No. All right. Well, thanks everybody. I will stop recording and hopefully have this up on the YouTube site within a couple weeks as well too, for those who want to look at it. Thank you.